to the September meeting of the Addison County Democratic Committee. Appreciate your all being here. It is 5:30 and we always start on time. We also end on time. Very important to keep the schedule. My name is Dave Silberman. I am the acting chair of the Addison County Democratic Committee. I am also your high bailiff here in Addison County. Ask me later what that means. And I'm really glad you're all here for our panel on traditional Medicare versus Medicare Advantage plans. I do have a few committee business matters to dispose of very quickly, and we'll get to those in just a minute. A couple of brief remarks. It is reorganization time right now. Our town committees are holding their reorganization meetings this week and next week. There is a flyer up right there where it says time to vote, listing each town in this county and where and when and what day their reorganization meeting will be. I urge you all to organize at the local level. That is the most direct way to influence how the political world around you works. We'll be having our county reorganizational meeting a month from today, Monday, the 16th of October at 5:30 right here in this room. And all are welcome. Anyone is welcome to an organizing meeting as long as they've not participated in the organizing meeting of a different political party in that election cycle. You don't need to register as a voter in a particular party. All are welcome. On Thursday, October 12th, at American Flatbread, the Addison County Democrats will be hosting a social fundraiser. Tickets start at $50 with a pay what you can option. See me afterwards for more details. Would love to see many of you there. And with that, I'm looking around the room and I see we do not have a quorum of voting members of the committee, so I will not entertain a motion to approve the minutes of the last meeting. Instead, I will ask John Spencer to give us a brief treasurer's report. John?
Yes, we've had some donations from the fall fundraiser, and had some expenses totaling about $389, and a balance of $5,276.16.
Thank you, John. I don't see any questions for the treasurer on the report, and so with that, we can move on to the main order of business of the night, which is our panel on traditional Medicare versus Medicare Advantage. This is going to be a panel discussion amongst several experts in the field. I will introduce you first to our moderator, Cheryl Mitchell, and then Cheryl will take the helm from there. Cheryl Mitchell was the Deputy Secretary of the Vermont Agency of Human Services for 10 years. In her prior role as co-director of the Addison County Parent-Child Center, she learned firsthand how difficult it is for people to access health care. She is currently president of the Early Care and Learning Partnership, a group promoting the well-being of all children and families. Cheryl, take it away.
Thank you, Dave, and thank you all so much for being here. I will put the mic a little closer, thank you. I'm a person with a soft voice. Is that better? Okay. I want to thank you all for taking the time to be here to learn about and ask questions about this important issue. We'd like to thank the Ilsley Library for giving us this space and Middlebury Community Television for recording it for us. I believe it will be available later to stream for your friends and neighbors who maybe missed the session tonight. It's going to be my pleasure to introduce the panelists. I do want to say, Dave said that we'll end on time, but we invite everybody who's here to hang around afterwards for pizza and ice cream. And for more questions with your live panelist, who's Mike Fisher. Sorry for those of you that are on Zoom that we can't feed you as well afterwards. But we'll also mention some resources. Many of them are available here, and we can follow up. So if you have questions that don't get answered tonight, we'll be able to answer your questions and do resources. I'm going to be primarily a timekeeper. This is, as you know, a complicated issue. Many of you have probably seen myriad I don't know if they're called solicitations on television to switch from your traditional Medicare into a Medicare Advantage plan. You've probably gotten mailings at your house. We've all wondered, what do I do about this? It sounds appealing. Does it make sense? Our first panelist is going to actually go quite a bit into depth for us, and then we will have 3 more people, 2 on Zoom and 1 here in person with me, to give their perspectives. I'd ask you to hold your questions until all of our panelists have had a chance to speak, and then we'll take questions. We'll have ample time for Q&A. Any questions before we get started? I think you all know this library, but there's restrooms down the hall if you need them. And in the corner. Okay. So our first panelist, and we're very grateful to him. We had hoped he might be here in person, but he's recovering a little bit from, I don't know if it was just a scratchy throat, but it's Dr. Marvin Malek. He received his medical training at SUNY Upstate in Syracuse, New York, did his residency training at Cook County Hospital, and earned a master's in health policy at the Harvard University School of Public Health. Dr. Malek has spent most of his career in community medicine. He was the founding medical director of 2 primary care facilities in the region and has practiced hospital medicine as well. In efforts to support the transformation of the U.S. healthcare system from its current status of being a massive, cruel, and completely unaffordable human rights violation, he has hosted a radio show, run for political office, served on the Green Mountain Care Board, served as president of the Vermont Physicians for a national health program for several terms, helped found, develop, and precept an intensive educational summer course for progressive medical students, and worked with labor unions for their health care rights. So please join me in welcoming Dr. Malek, who will be showing some slides as well.
Hear me okay? All right. So first of all, my name is Marvin, and thank you so much for the introduction. I, in fact, do have some slides, and technical reasons, the host has disabled screen sharing. So whoever's the host in this meeting, if they could enable it, that would be great. And in the hopes that Dave Silverman or others are able to do that, I will start out without slides and hope that eventually we will get to them. All right, well, I guess I'll try now then. Okay, so the purpose of this presentation is to try to understand the history of the Medicare Advantage system and its business model and how that impacts the public, and in particular people who sign up for such a plan. And as you all may remember, after World War II, Harry Truman proposed a single-payer plan to cover everyone in the country. The AMA nixed that with an unprecedented, massive lobbying campaign, and what that left was employer-sponsored health insurance, with the strong union movement at the time had gotten as a benefit of employment. You know, over a third of the American labor force was unionized at that time, and seemed reasonable to try to get health care coverage. So they did that. And unfortunately, that left the people who weren't working or were working in gas stations and other jobs where wouldn't be feasible, affordable to provide health coverage. All those people, plus the elderly, ended up with no coverage. And what you saw at that time was one of the movements of the 1960s was not just civil rights, but there were many movements during the 1950s and 60s, and one of them was to get health coverage for the poor and the elderly, at the very least, if not a universal plan. So let me move on. So as part of the Great Society legislation, Lyndon Johnson signed in 1965 to, after the bill had passed Congress, to enact Medicare and Medicaid. And you can see that Medicaid was to cover the poor and Medicare the elderly. You can see to the right, Harry Truman is the first individual signing up for the plan. And and also this is what the sign up process was. It was a postcard sent to people's houses. And this got 16 million people signed up within 6 months. It was quite remarkable. A contrast to the sign up for Obamacare, which was so very complicated. But unfortunately, the Medicare legislation has a lot of holes in it, and in particular, deductibles and copays. So there are big copays for Medicare, for hospitalization, which is Part A of Medicare, and there are big copays and deductibles for Part B. Part B is extremely important because that's what covers all doctor visits, primary care and specialty. It covers labs, it covers x-rays, all types of testing, chemotherapy infusions. So Part B is huge, and the way the legislation was set up, the patient pays 20% of all cost of the Medicare approved amount. So could potentially a huge amount of money, especially nowadays when chemotherapy drugs can cost 100,000 plus a year. So paying 20% of that would bankrupt a whole lot of people. So I don't know all the reasons why the benefit was set up to be so poor. One of them was healthcare didn't cost nearly as much then as it does now, by literally orders of magnitude, even adjusting for inflation. So Medicare needs improvement. Basically, everybody who's below 400% of poverty who's in the Medicare program has large numbers of people have trouble paying it or are paying 20% or more of their income on all the out-of-pocket costs that Medicare doesn't cover. So now let's look at this history from the point of view of the insurance lobby, the insurance industry. When they saw that the poor and the elderly were going to be covered in 1965, they said, well, great, let the taxpayers have the elderly and the poor. They're way too sick. We don't want anything to do with them. They cost us a lot of money. So they were quite content with the situation. But as time went by, they gradually came to see that their market in the 1950s and 60s had pretty much reached the limit of what it was going to achieve. That people who ran gas stations or restaurants often could not afford the ever-increasing costs of providing employer-sponsored insurance for their employees. So you can see that, especially as a percentage of the population, and this is a percentage of the under 65-year-old population, this was already peaking by 1980, that they weren't going to really get more customers in the under 65-year-old labor force. They had no effective way to make their product any cheaper, and also it was a little unstable. For example, if you go to 2007 and 2010 on this graph, you can see that the number of people with employer-sponsored insurance plummeted between 2007 and 2010 due to the economic calamity that occurred over the housing greed that we all were all affected by during that period. So they were looking for another way to make money because they weren't going to be making any more in the under 65-year-old privately insured population. So when it came to senior citizens, they looked back, they took a second look. They said, well, actually, not all of them are sick. We could insure the ones who are healthy, maybe. So in 1982, this was the first time that there had been subcontracting of the Medicare benefit. In other words, CMS, which is the Medicare or bureaucracy, whatever you want to call it, would make a fixed monthly payment to a private plan for each Medicare beneficiary that it enrolls. And the plan then would become responsible to fund all medically necessary care included in the Medicare benefit. All medically necessary care that Medicare would otherwise cover. So we're going to get back to that term medically necessary a little later. Ronald Reagan had just come in office the prior year, and he had said that government's not the solution to our problems, government is the problem. But of course, to people who are on Medicare, their hospital care and their doctor care had substantial coverage now. So maybe government didn't seem so bad to those people, the elderly, and to the poor, who now could access doctors and hospital care. But this was the new model, that you would insert a middleman or middle person to manage the care, quote, manage the care, as if the care needed managing. And so this was the model, starting in the 1980s. And so from the insurance industry's point of view, Uncle Sam was a much more reliable, deeper pocket than a restaurant owner or a business that could be affected by the economic cycle of capitalism. So they decided that because these private plans, everything in the private sector is supposed to be more efficient, that instead of paying 100% of the cost to the average Medicare beneficiary, they would pay 95% of the cost, Uncle Sam would, to insure that person for all of what Medicare would cover for a year. But the insurance people didn't just look at it that simply. They had a more sophisticated way to look at it. And this is the most important graph I encourage you to look at carefully and understand. And what the graph shows is that 1, 2, 3, 4, 5 are each 10% of the entire population. This could be the Medicare population, people over 65. And on the left are the healthiest 10% who don't cost anything or not very much. And on the right are the most expensive 10%. And you can see that the most expensive 10% by themselves are over 60% of overall healthcare costs. And if you add in make it 20%, that's now up to being around nearly 80% of all healthcare costs, 75% to 80%, just in the people who are sickest. This is the graph that is on the wall and in the head of every person who runs a health insurance company. Why it's not in the heads of legislators and government officials is beyond me, but it doesn't seem to be, except when it's foisted on them. But the health insurance industry know all about this. So they look at these people and they said, well, these are the people we want, and maybe this is the guy maybe we don't want because he looks like he might need to go to the hospital. In fact, he may need to go right now. So he's going to be over on the right side of this graph, and those other people with the weightlifting, they're going to be way over on the left side. They're going to be not a whole lot of money. So you can see that by avoiding those two deciles, those bars on the right, avoiding that fellow that we just saw, him, they could probably really make a killing and make a whole lot of money. And in fact, that's what they set out to do. So, that was really the model, and that's what's been the case all along. But it became very clear very quickly that through clever advertising, like, for example, advertising in the business pages of the Wall Street Journal, but never venturing to a nursing home to sign people up there, that they ended up with a population that was not merely not costing 95% of what the average beneficiary was costing, because those expensive people are included in the average. So they were picking off the healthy people and making a killing. So the act that actually got pharmacy coverage in 2003 also renamed the Medicare, the pre-existing subcontracting business that I just described, and they formally called it the Medicare Advantage system. So but that was basically a renaming of what had already existed. And because they were being so severely ripped off with the 95% payment scheme, they created a coding system in which people who, say, had diabetes and heart failure were they would get the plan more money than if the patient had no problem at all. So you were going to code, everyone was going to code for what kinds of illnesses the patients had, and that would determine the Medicare payment for each year. And also, the plans that had extra profit were able to provide extra benefits. And one thing you should understand all the way through this is that basically, due to effective lobbying, Medicare Advantage plans are set up to be profitable. They start out with very substantial profit due to government overpayment in the formula. And I can explain how that formula works if you want to ask the question, but it would take 2 or 3 minutes, and I don't have that long. So basically, they're being overpaid, and they were also that Act of 2003 said they could provide extra benefits. So let's look at the benefits that they were able to provide. That list is on the left, ranging from caregiver support to telemonitoring, bathroom safety, and including eyeglasses and dental. But what the percentages those bars show is what the plans actually have ended up doing. And so, keeping in mind that old fellow who's in the bed, he's probably going to need caregiver support and a whole lot of help at home and in the bathroom. And those are expensive things to provide. And really, they kind of don't want him in their plan anyway. So what do they provide? A fitness center coupon. So the people who are doing the weightlifting, they may take advantage of that. And healthy people would also maybe need hearing aids and eyeglasses. So they decided on which plans to provide with marketing involved. Who did they want to have sign up? And these graphs show that over time, the amount of money or revenue in this case that they're making from the under 65 population, which is the powder blue, has been virtually stagnant, not merely for these 6 years, but for a lot longer than that, as I showed earlier. But the amount of money they're making from the government plans is mushrooming, and that's just in 6 years on these graphs, but believe me, it's continuing unabated. So here's how they make profit: maximize revenue per patient, minimize expensive, and increase the number of customers. So here's the kinds of things they did: lobby for high payments, which I already described to you. They also distort their quality data. It's a typo. And that gets them more money. And upcoding and risk score gaming is the key part of it. They also don't even have to pay for hospice care when their enrollees need it, which is by itself a huge scandal, just huge. But since the big one of these is the risk score system, let's go into that just for a couple of minutes. So if you're a healthy 76-year-old in this coding system, you end up with a code of 0.45, and that gets an annual payment to the insurance company of $4,000. But let's say you've got some health problems. You're obese, you have type 2 diabetes, major depression, heart failure, asthma, some sort of skin ulcer, and that's an interaction code. Your risk score with those health problems ends up at 1.03, and CMS, the Medicare agency, pays the insurer $9,000 for that year. But let's say you bought the software, which software vendors developed within 1 year of that coding system being rolled out in 2003, and you use the software, and what you see here is that they call it morbid obesity, and that gets their code up to 0.273. They note that there's even mild retinopathy, and that will get their code up. Instead of major depression, a single episode mild of major depression. I'm not sure I know what mild major depression is, but that's what it is. And that got them 0.395. Heart failure got them, as before, a lot of money. COPD ends up coding much higher than asthma, even though they can be difficult to differentiate for a doctor. And they simply staged the ulcer at stage 3 and got them a bunch more money. So the very same patient that coded casually when one wasn't paying attention to what the agency likes to fund, the payment for the very same patient goes up from $9,000 to $32,000 a year. And this is a key element of the business strategy of these Medicare Advantage companies. So the companies have become masters of coding, and it's pretty much mostly cheating. So unsupportive risk adjustment payments. And what you're seeing is that the more expensive the Medicare Advantage plan is to CMS by basically upcoding and making everybody in their plan look sick, the better the benefits, because they're getting more money from Medicare, and they can then provide better benefits, the eyeglasses, and even lower premiums and lower copays potentially. And then they can attract more members and grow more quickly. So it's kind of a vicious cycle of them getting ever more profit.
Wow. Marvin, thank
So
you
the
so
idea-
much for going into these
The
details.
idea is they incessantly search.
Sorry, Marvin, just 1 second. Marvin, I'm going to interrupt you for 1 second, and go ahead, Cheryl.
Okay, I was just going to say thank you so much for giving us some really detailed examples of how this works. I think that you had offered to come back later during the Q&A session to go into even more depth on this. I think we should take a few minutes and have our other panelists present, unless you're almost, at the end of what you'd like to tell us.
I'd say about 5 minutes.
Okay.
You want me to go ahead, or do you want?
Sure. Why don't you go ahead for 5 minutes, and then we'll.
Okay. So in this graph, this talks about the overpayments. The yellow is what's from lobbying. The blue is basically cheating, upcoding. And then the second strategy is to minimize revenue. And they do this. You can see their overhead and profits are considerably higher. And the Office of the Inspector General of HHS found that Medicare Advantage organizations were denying prior authorization requests completely inappropriately without any foundation, as well as denying payment for medical care that was already provided. Those are usually in the hospital, and what they found was 18% of denials were inappropriate, and a little less than that for prior authorization requests. So because of all the denied care, sicker people tend to leave Medicare Advantage plans because they can't get the health care they need, or their preferred provider was not in the plan's network.
Right.
So and this graph just shows another way that people who required post-hospitalization nursing home care were very likely to leave Medicare Advantage plans. And I can play the Joe Namath video. It would take 1 minute and 3 seconds. I guess I won't do that. It's a great video. I can show it later if you like. And this kind of summarizes the situation. To get into the middle column is Medicare Advantage. To get into it, it's $2,158 a year. Most of that is the Medicare B premium. On the other hand, to get a supplemental plan, which is your other option to avoid terrible coverage within plain old Medicare, you have to pay just about double that, $3,967, to get the Medicare B premium plus a supplemental plan. On the other hand, the Medicare Advantage plan has copays on virtually all non-preventive services. They rise substantially for expensive services, and there are caps, 12,435 if you stray out of network at all and need to see a doctor who's not in their little panel, and that's in addition to the $2,158 to get into the program for Medicare B premium. On the other hand, if you buy a Medicare supplemental plan, all you pay is the $3,967 to get in and a $233 deductible. So in other words, beyond the $4,200, you're covered. You don't need to worry about what might happen to you during the year medically. And then in terms of all this prior authorization stuff, that does not happen in traditional Medicare, and it doesn't happen with a Medigap plan. It's only Medicare Advantage where you have to worry about that. 2 million of them, prior authorizations, were denied last year. 35 million of them were required by plans, driving doctors crazy. And keep in mind that in regular Medicare, with or without a Medigap plan, the doctor determines what's medically necessary. And if you're in a Medicare Advantage plan, the plan determines what procedures or tests or treatments are needed. And then finally, a choice of all providers, if you're in Medicare or who are in the Medicare program, which is basically 93% of doctors. On the other hand, networks in the Medicare Advantage plans can be quite narrow. So there's the summary version. Advantages for Medicare Advantage is much worse for the taxpayers. We're losing a lot of money on it every year. It's much cheaper for the taxpayers if you stay in traditional Medicare. It's a bigger hassle for doctors, especially because of the prior authorization. Payment rates may be better if they actually pay the bill, which they often don't. And as far as patients, the impacts on patients, as I said, much lower premiums if you're in a Medicare Advantage plan. Disadvantages for patients, the copays, the denials, the prior authorizations, which may get denied or at least delay, the networks, which can be pretty narrow, and the exit penalty, which we haven't talked about. But if you try to get out of a Medicare Advantage plan and buy a Medigap plan, they can refuse to let you in, or they can charge you more. Blue Cross of Vermont charges, I pay $164, and if I were in a Medicare Advantage plan and then went to Blue Cross to get the same plan, it would be $260. So they can charge more, and Blue Cross in fact does. They don't deny people entry like some plans do, but they charge more, and that's for the rest of your life, as long as you're going to stay with Blue Cross of Vermont. So that's the summary version of all this. I'm sorry I went over time.
Oh, no, it's great to have this really solid background about what it is, what it isn't, the pros and cons of it. We're going to stay with the virtual presenters for a moment. Dr. Betty Keller from St. Johnsbury served on the faculty of the University of Utah Family Residency Program prior to returning to Vermont. She's president of the Vermont Physicians for a National Health Program, co-chair of the Education and Advocacy Work Group of One Payer States, and she's chair of the healthcare committees for the League of Women Voters. So, Dr. Keller, we'd love to have you comment briefly from your perspective, and then we'll address maybe the issue that Marvin didn't have a chance to go into about getting out of Medicare Advantage.
Has my microphone been turned on?
Yes.
Great, thank you. So I'm Betty Keller from St. Johnsbury, and I am the current chapter, took over after Marvin, and very happy to see so many people that were interested in this topic and willing to learn more about it. And I would be very excited if more of you wanted to learn even more after this evening and work on advocacy for strengthening our Medicare program, protecting it, and ideally expanding it to all. The organization, Physicians for National Health program, is 35 years old this year, and it has focused on advocating and educating on Medicare for all its history. Historically, more recently, since roughly the time that Vermont was acting, seeking Act 48, they have had chapters that choose to support state-based single payer as well, but that's not a focus that the national organization does. And more recently, though, they have been looking at how to protect Medicare, both to preserve our Medicare trust fund and to protect seniors, but also to protect Medicare, because as it gets more and more privatized, it's harder to explain to people, yes, we want to improve it and expand it, and they say, yeah, I don't want to be on that. So we need to be protecting our Medicare as well. The Vermont chapter was supportive of the efforts for Act 48, and after the governor chose not to submit a budget to implement it, we turned our attention to our internship, which Marvin is one of the primary faculty for, and that has been a wild success. That we currently have been doing it by Zoom and have been having up to 14 interns from across the country. We're talking, Arkansas and Louisiana, Texas, Arizona, Florida, and the middle of Midwest too, not just out there, as well as the East Coast. So we're very excited about our outreach to medical students across the country, because unfortunately, doctors have been a huge barrier to medical care, to healthcare for all in our country. They, along with the insurance industry and pharmaceutical industry. And so, so we'd be very excited to have folks here share with their doctors that we exist, because it's not a widely known organization. We'd love to have more doctors that would join us. We would love to help Vermonters figure out how they can advocate for national health care, and also how, if they're inclined to help other states seek state-based health care, we could help them figure out how to do that. And if you say, well, that's not that much to do in Vermont, our legislators already support it, and our congressional delegation is supporting Medicare for all, I can find you really useful things to do trying to support other states in getting their legislators, their congressional delegations to also support it. There's always work to do. So thank you so much for your time. And I'm happy to speak with others later. I've put some things in the chat which you folks can't see. On the back here, I have the email address vermont@pnhp.org. That gets forwarded to my personal email, and then I will get back to you. And there are a couple of QR codes that I'm hoping Dave can put up. One of them is for a survey form that you can fill out, where you can share your email address with me, and that way I can get back to you about volunteering. And the other is to find out more information about protecting Medicare. It's called protectmedicare.net, and it goes into, it has little videos explaining some more of what Marvin's been talking about, and also sharing petitions that you can sign. And very excited that you folks have invited us. I do want to point out that that this should be a nonpartisan issue. This should not be a us versus them tuggle in Washington. Everybody should want to take care of our neighbors and across the country, regardless of their background, their zip code, their ability to pay. We should want to take care of each other. And so I would be urging you to reach out to me as an individual. I don't want to be partnering with a particular party in the long run. For educational events like this, certainly, but not for developing strategy and things like that. We need to maintain our nonpartisan position. Thank you.
Right. Thank you so much, Betty. Really appreciate it. And I'm sorry for the interesting sound effects, but people were able to hear you. I hope that in the recording they'll hear you well too, and be able to follow some of your resources that you've offered. We're going to switch back to this community room for a moment, and Mike Fisher is going to talk to us some. Mike Fisher's been working on Vermont health policy for a number of years. I have to say that Mike and I used to work together at the Parent-Child Center. He knows this from the ground up. When I was at the agency.
I was 12.
He's been coming at it from the perspective of being a legislator and trying to understand how to actually make policy changes. And he's been in the leadership of the House Healthcare Committee during a very important years, and more recently, he's the state healthcare advocate. So thanks.
Great. Thank you. Good to be here. Let me start with maybe a question that's, I don't know if I'm allowed to ask this question. I don't know if it's proper to ask this question, but I'm going to ask it anyway. How many people here are on Medicare now? No, I just said Medicare. I just, so broadly, Medicare. And so, so everyone will ultimately have to transition to Medicare if we're lucky enough. So let me say a little bit about my organization. The Healthcare Advocates Office is a project of Vermont Legal Aid, but we're defined in state statute. We're fully funded by the state to be a public advocate, a watchdog about the healthcare industry, and to provide we provide a helpline for people who have any kind of access to care problem. There's no income eligibility for it. You just have to be a Vermonter. And we have a staff of lay advocates that are there to help people out. People call us with this question. Hey, I see these ads on the newspaper. I see these ads, or hear these ads. By the way, we're coming up to the Medicare. I'm going to call it Medicare Part C. Everyone so far has called it Medicare Advantage. Everything in Medicare has at least 2 names just to make sure it's confusing. When I say Medicare Part C, it's the same thing as Medicare Advantage. I don't call it Advantage. It's not an Advantage. So I don't use that phrase because I think it's marketing. It is Medicare Part C is how I will refer to it.
Could you adjust your mic so you speak straight into it?
Sure. Sorry. Let me do a sound check. Can people hear me now? So starting on October 15th, so in about a month, the open enrollment period, the annual open enrollment period for Medicare Part C will start. And if you're not already seeing tremendous amount of ads, you'll see more. And these ads are regulated. They're not. There's nothing about it that's regulated on the state level. It's all federal law. And so traditionally you see, famous football players saying how good it is, and you see lots of promises about how much it's going to cover. And so, let me just tell you a little bit about the lay of the land of the law. In Vermont, as Marvin said earlier, regular Medicare covers about 80% of the costs. And so if you want coverage for that 20%, you need to get a secondary, you need to get additional coverage. And so you generally have a choice about getting a Medicare Advantage plan, which will cover that 20%. Oh, I said Advantage.
You said it.
Part C plan, or you can get what's called a Medicare supplemental plan, again, just to make things confusing, often called Medigap. So Medigap or a supplemental plan to cover that 20%. In Vermont law, you have just a single 6-month period where you can buy a supplemental plan. So 6 months after you buy a Part B plan, you can buy a supplemental plan and have guaranteed issue. They have to offer it to you, and community rating. They can't charge you extra because of your health status. So 6 months, that's all you got. And if you don't do it during that period, you no longer have the guaranteed issue community rated option. So again, an insurance company can turn you down for it because of your health status. Marvin did cover. Blue Cross chooses not to. Our Vermont Blue Cross chooses not to. And they can charge you extra. I would call it a penalty. It's medical underwriting. They charge you more if you don't buy it during that period. The reason I'm going into that detail is because if you miss that 6-month period, it costs you more. it will cost you more. So,
Full disclosure.
yeah.
I'm an insurance agent. I sell Medicare policies.
Mm-hmm.
If you get by that period and you're in good health, you can apply anytime. So you're not, it doesn't cut you off.
Yeah.
Only if you're not in good health.
So,
And there are companies that will write, there's one company that will write anyone unless they have end-stage renal disease. That's it. No other question.
so the reason I'm going into this detail, so let me pause and say something for a second here. I want to recognize this is really complicated stuff, and you can mess up, and you can mess up and end up having penalties for the rest of your life if you don't do it right. So I'm saying some complicated things. Don't take advice from me. You gotta check. You gotta look. You gotta get advice from somebody who can look at your individual situation and give you direct advice. And I would suggest you get advice from someone who's not trying to sell you a product.
You're not being a good salesman.
So the reason I went into all those details is because for people who buy a Medicare Part C plan, they can lose that opportunity to get that guaranteed issue community-rated product. They've got 1 year. There's another detail. I'm sorry, it's all complicated. You've got 1 year on a Part C plan where you can go back to traditional Medicare. But if you miss it, then you've lost that guaranteed issue community rated period. And so Vermont, every state's not like Vermont. This is, a ton of this stuff is completely federally regulated, but not all of it. The open enrollment period for Medigap plans is a state option. Vermont has the federal minimum of that 1 6-month period. Across the lake, New York has continuous open enrollment for Medigap plans. So I want to recognize that Marvin did some of this earlier, but I want to recognize if it doesn't matter what age you are, if you're healthy and you get very little health care, how do you evaluate whether your insurance is good or not? I think it's really just one factor. How much is the premium? That's all that matters. Premium is low, I've got great insurance. So the next day you step off a curb and you need some care, or you get a bad diagnosis and you need some care, or oh my God, you need a skilled nursing facility or a rehab. And suddenly you're into a world of dealing with your insurance company, and you find out whether your insurance company is going to meet your needs or not. And I want to tell you that we get calls, it is a regular call at my office from people who say, I thought my Part C plan was great. I had 0 premiums. I thought it was great. And then I find out it doesn't meet my health care needs when I needed care. Now again, if that happens to you in your first year of Part C, you get to go back. But if it happens afterward, you're kind of stuck. So I think I'll stop.
Okay. But,
And
yeah, thank you. And it's great to have some people from different parts of this industry. We're glad that you're here. We have one more speaker
you know
who's
what,
remote. Tom's not here?
Let me give
Okay.
one more number, because Marvin gave the national numbers. I thought I would give the Vermont numbers. In 2017, Vermont had 9%, they use the term penetration rate. 9% of Vermonters on Medicare was in a Part C plan in 2017. And in 2022, we're up to 27%. So there's a tremendous growth in Part C uptick, and that has continued even beyond that. And again, this is going to be technical, but it's going to be based off of something that Marvin said. There's a direct relationship between the cost of the traditional Medicare population and the uptick to Part C, because Part C plans are good at getting healthy people. That leaves behind the people who cost more. So Vermont has been known as a low-cost Medicare state. The traditional population in Medicare has been low-cost, and that's because we've had a very low uptick, take-up rate in Part C. That's changing. Vermont is catching up with the rest of the country, which means that the Medigap rates are growing and are going to continue to grow.
Wow. Thank you. So we can open the floor. I think we'll go back and forth between those who are following on Zoom and those of you who are here in the room. So if you have a question, if you could just say who you are, where you live, and if it's to one of the specific presenters, let us know that. If it's a general question, they'll jump in and try to cover
Right,
it.
so
we have
I
one
will,
here.
we'll
You
recognize
monitor on
hands
Zoom?
in 1 second.
Okay.
Just for you, for those of you on the Zoom, please use the raise hand feature, which you'll find under the Reactions tab at the bottom of your screen. And for those of you here in the room, just raise your hand and Cheryl will call on you.
So I'll call on this gentleman first, and then Dave, if you see people on the screen who have raised their hands, that would be great.
Great, thank you very much. I guess, Mike, this is probably for you then. On your uptick in the Part C sign-ups, does that include like the teachers' retirement? Are they part of that Part C in your mind? Because they got shifted over to Advantage.
That's a great question. I'm not sure that, well, that was for 2022, so that was previous to the teachers moving over.
But you would consider that a Part C plan?
It is a Part C plan. I want to, I guess I want to recognize all Part C plans are not the same. And, you know, the major actor in Vermont is United Healthcare. You know, you probably hear more ads from Blue Cross and MVP lately. But the plan that the teachers created for the retired teachers was intended to mimic the benefits that they had contractually, that they had through their contract. I think my understanding is that they are not seeing some of the same complaints out of Part C as the general population. But there might be people who have personal information about it.
And there's some state oversight, right? It's not, it doesn't exist for other Part C.
For the folks on the Zoom who can't hear the audience, let's just repeat the questions when
Okay.
we answer them.
So, but to your last point about how well that will maintain over time, I think that is the risk. Will it maintain over time, and will the state continue to hold Blue Cross, in this case, or accountable to that, and or will they shift to a different contractor at some point? I think that is the concern for those collective bargaining units, the teachers and the state employees.
Dave, do you have somebody on Zoom who wants? Okay, so I think you were first, and then we have 3 here.
My question is, how many of the teachers, after getting switched over to the Medicare Advantage bailed? Because I know of a couple of them.
I'm sorry.
The question was how many people bailed after being switched over?
Bailed, went back to Medicare and did a supplement. There's a guaranteed issue on the supplement with it.
I don't know how many shifted, though my understanding was that it was on their dime to go to the traditional Medicare. So I would suspect few would choose to, they have a benefit through their through their retirement, and that they're not going to take that. And but maybe some did. I have no idea how many. You did.
When our
Yeah.
Medicare and
Yeah.
availed themselves to the open enrollment
Yep.
for the supplement.
Right.
So to clarify for a little bit, when you say Part C.
Steve, just 1 sec. I'm just going to make this easier.
Thanks, Dave.
You're using the Part C as a synonym for what we've been calling Medicare Advantage?
That's correct.
And
And when you were talking about the teachers going back to the traditional, you meant to go back to the traditional with supplement. Otherwise, they'd have to pay the 20%. Is that correct?
That's accurate. Thank you.
Of course, supplement is a synonym for Medigap.
You got it.
Dave?
Hi, Mike and Cheryl. Thank you so much for doing this. So I'm a retired teacher. I was on Part C Advantage in 2022. So whether those numbers are included or not, I am curious. So I got a notice from the retirement people that open enrollment is until November 15th or something, and they can.
It's through my birthday,
Yeah.
December 7th.
And they did that on purpose. So they can't even talk about the new plans until October 1st, and then on October 15th, they can give me more details. So I have like 1 month to figure out what's best for me. I've been on Part C for 1 year. Does this mean that I can switch back to Medicare, regular Medicare, and get a supplemental plan, which is offered through the teacher's retirement? I don't believe it was last year, but it is currently offered.
Boy, that's news to me that the teacher's retirement is offering a traditional Medicare with a supplemental plan. By federal law, you have 1 year to go back to the traditional, but.
We can try to track that down, I think.
Just trying myself.
Okay.
I
Mhm.
called today, as a matter of fact, spent an hour on
Yep.
the phone trying to figure it out.
We did have another panelist lined up who's the man that advocated for the retired state employees to not go onto a Part C plan. So he also might be a good resource for us. There was a question right here.
The treasurer's office negotiates for the 15,000 educators and the state employees. The employee gets theirs for free, and the monthly payment is for the spouses and if there's family. Or you can, now there will be the option, I'm not fully sure what's going on with the Medicare Advantage plan, but I hate to say it, we have the Cadillac of plans. So I don't see why anybody would change it. And I think we have to look better at the whole system and keeping people healthy regardless of the cost. But anyway, any educators, theirs is paid, and it is being changed with the Medicare Advantage, and the information, like Dave said, will be out soon.
I think there will be more resources available, not just on this, but also to the issue that you talked about, not just Medicare versus Medicare Part C, but also can we move towards Dr. Keller. Dr. Keller mentioned some of the work that she's been doing in the national work, so we'll try to get you some of those resources that's even broader than just the Medicare Part C. Dave, you had a question, and then you had a question.
Dave, too.
Everybody's named, they're all not named Dave, but.
Yes, interestingly, I've been getting promotional ads on Facebook for Medigap programs right now, the new Plan G. But what I wanted to ask about was what we make of the alliance between MVP and UVM Health offering a Medicare Advantage program, which I happen to have been on for the last 5 years, and I'm a very happy customer. But I share all the concerns that have been raised about the pillaging of the trust fund. And I know Martin's Point over in Maine has actually been prosecuted for doing that, so.
Good
Yeah.
point. I'm just saying, because we only have 1 minute, and you could maybe have the last minute. You're going to let this question stand. Same question. Okay. You wanna answer?
So that does give me an opportunity to say, hey, there's some people really happy with their Advantage plans and it works well for them. I want to recognize that. There's sort of national policy and the protection of the Medicare Trust Fund. I don't think there's any dispute, or maybe I should say in my mind, there's no dispute this is bad policy nationally. But there are people who have Part C plans, and it's meeting their healthcare needs, so I want to recognize that. I want to just say briefly that I attended and participated in the UVM Health Network budget discussion in the last couple of weeks, and we asked UVM a number of questions about their partnership with MVP. Their answers were baffling to me, that they claim that there is no financial advantage to them for participating in this. That is baffling to me. It cannot be. So I guess I want to say I and my team have some more work to do to understand exactly the flow of money for UVMs. For MVP, I think it's clear, but for UVM.
Thanks, Mike. Let's let Dr. Malek have the last word here, and then we invite all of you to stay who are here. We'll probably close the Zoom. Is that accurate? Okay. So Dr. Malek.
Yeah, I just wanted to make a comment about satisfaction with Medicare Advantage plans. They tend to rank very high, and I think we've heard why, because they're polling people who stay in the plans. And the majority of people in health plans are the 80% of people who are healthy. And the plans look pretty good because they're constantly encouraging you to get preventive care measures that don't cost them very much, like mammograms and immunizations. But try getting cancer and we'll see how many people are satisfied then. And I promise you the number goes down substantially. So it's more helpful to survey the people who leave plans, find out why, rather than surveying 80% of people who are healthy who stay in them. When you look at people there are people who would benefit from being in a Medicare Advantage plan, but they only know that in retrospect. In other words, if you're 65, you get into a Medicare Advantage plan, you pay very little for the first 3 years, and then you develop a severe illness and die in 3 days, you would have benefited financially compared to having to pay the larger amount of money to have a Medigap plan. So there are people who appear to benefit, but you only know that in retrospect. And the whole point of having insurance is that you don't know if you're going to end up on an expensive medication or need fancy tests or have a type of health problem where you really need to go out of network because it's a really rare problem. And so there's a lot of issues with just looking at people who survey saying they're really thrilled, because it's deceptive.
But Mike wants to say one more thing. I just want to thank Dr. Malek and Dr. Keller in case they have to leave.
I just want to, because I haven't managed to mention it, and because there are a few policymakers in the room, legislators in the room, the Healthcare Advocates public policy major push this year is about Medicare affordability, and it's about how we are absolutely failing low-income people on Medicare, and there's options for us to do better, and our neighbors are doing better. We sometimes have this concept of Vermont exceptionalism. We do it right here in Vermont. We're not doing it as well as our neighbors. Other than New Hampshire, we might be doing better than New Hampshire. But other than that, our neighbors are all doing better for making sure low-income people on Medicare, that is older and disabled people, have access to care.
Okay.
Thank you.
Well, thank you all. I think Dave might want to close us. Do you want to give us
Yes,
a few
thank you.
closing
Thank
words?
you, Cheryl and Mike and Marvin and Betty, for your insights and information this evening. We're going to close the panel discussion at this point and briefly, Betty, go right ahead, Betty.
Hi, can you show those QR codes so that people can aim their camera at it and then?
Yeah, Betty, I got those printed out on our back table here, actually. So Betty has 2 QR codes for folks who want to find out more information on her organization, the Physicians for National Healthcare Plan. So we've got that right there by the pizzas, so you can't miss them. So again, I'm going to close the panel discussion. Thank you, panelists, for being with us. This was extremely informative. Look forward to it being extremely relevant to me in about 18 years. Excellent information indeed. So we're just going to quickly return to the Addison County Democratic Committee agenda, which will take just a couple of minutes. And I'm going to make a couple of quick announcements. One is that, again, we are in the middle of committee reorganization, once every 2-year process. It begins with town organizational committees, town committee reorganization. There is a list of dates and times and places right there on the wall. Please look it up. Please join your town Democratic Committee. And secondly, on Thursday, October 12th, the Addison County Democratic Committee will be holding its fall celebration fundraiser at American Flatbread right here in Middlebury. Again, Thursday, October 12th. We would love to see you there. And then is there, from any of the members of the committee, any old business? I see none. Any new business to bring before the committee? I see none. Any additional announcements from any members of the committee? I see none. That brings us to everyone's favorite motion. Would anyone like to make that motion? Steve?
I move to adjourn.
Steve moves to adjourn. The motion is seconded by Andrew. The motion is non-debatable, and so we'll proceed immediately to vote. All in favor of adjourning the meeting? I hear ayes. Do I hear any nays? I have had a motion to adjourn fail once. It was fun. The meeting is adjourned. Pizza is served.
Is that the legislature?